good evening from Hong Kong, good morning from the West Coast in the United States, and good day for anyone in between. This is the third Asia Times webinar on topics that we hope will be of interest to all and be captivating you with your attention. We're very proud to have persuaded Professor Ioannidis from Stanford University to speak to us this evening. And I want to give you just a very, very brief background on Professor Ioannidis. He is a teacher of medicine in the medical school of Stanford University, but he also holds a position in the humanities and statistics at Stanford. So if you look at COVID-19, precisely the kind of background, I guess, that somebody needs in order to make sense out of it all and you know, how it all happened and what to do about it. One of the areas that Professor Ioannidis is well known for is something that is called meta-research, that is to say the research of research. And what is meant by that is to critically assess the methodologies and the success of certain methodologies of research. And he has written numerous papers on that. And one, apparently, I learned from reading an article about him in Atlantic Monthly. One titled, "Why Most Published Research Findings Are False," has been the most accessed article in the history of public library of science, with over 2.5 million hits. So there are a lot of people who have their suspicions about the results of science, and I guess if one points that out and gives the statistical proof of that, this is an interesting topic for people to look at. But this is, of course, a very essential topic that we're dealing with and coping with right now when it comes to COVID-19. What actual conclusions can we draw, and what can we say in particular what went wrong in our approaches to this problem, to this pandemic, and at the same time, you know, where can we do better? As we all know, the likelihood, and it doesn't take Bill Gates to tell us that, the likelihood that this will happen time and again in the future is obviously very high. The way we're going to do this is Jonathan Tennenbaum, a very old friend of mine and the chief science writer for Asia Times, is going to join me in asking Professor Ioannidis various questions. So it's from the get-go something of a Q&A. And after Jonathan and I have gone through what we can ask, and then we will open the floor for questions from the audience. So we'll give you a signal when the time is ready. Professor Ioannidis, thank you very, very much for joining us. And would you please spend a few minutes to introduce the topic and the basics that you'd like to address? Thanks a lot.
Thank you for the very kind invitation, Uwe. It's a great pleasure to join you in this webinar. Clearly, COVID-19 has presented a major crisis. We're dealing with a highly lethal virus that has caught us off guard. The pandemic grew in a situation where most countries had very little preparedness to deal with something so major and so acute. It has also led to an unprecedented response in terms of the scientific effort to find information, to find reliable information, and to base our actions on that information. And it has also led to an unprecedented situation of using measures that, for some of them we had very solid evidence, but for others we had tentative evidence or no evidence, but we had to act very fast because we were dealing with a very acute and potentially highly lethal problem. So it's a major challenge. The challenge is evolving as we speak. I think that there's lots of people who are trying to do their best, and we do have very good tools across different scientific disciplines, but we also have lots of limitations and lots of caveats trying to deal with a virus that is a global problem. It's not something that we're just handling in the lab. It's something that we are trying to deal with the entire human population inhabiting this planet. And that's not an easily controlled experiment.
Mm-hmm. All right. Are we technically all right there? Or?
Yes, absolutely.
Okay. Okay, thank you, Professor Ioannidis, for the brief introduction. Jonathan, you want to just get going here and ask the first question?
Yeah. Dr. Ioannidis, well, you've spoken not quite as polemically as I was expecting, but maybe it will become that way. I saw an article of yours. I don't know if it's your title, but the title I found was "A Fiasco in the Making. As the coronavirus pandemic takes hold, we are making decisions without reliable data." So I would like first to ask, what were the reactions to that statement and to what you wrote there? But the more important question for me, watching this whole drama unfold, since the end of last year, and struggling to try to understand what's going on, is really the question: if decisions are being made without reliable data, why? Was there not sufficient effort put into getting the data? What does the situation look like right now?
So this is an article that I wrote in Stat in mid-March. It was at the time when the pandemic was getting old in the US. We already had the experience of China, and we had started seeing a disaster unfolding in northern Italy, for example. Mm-hmm. And I wrote this trying to highlight the fact that we were dealing with something that had tremendous repercussions, a potential for major harm to many people. We were taking measures that were draconian, that we had no precedent, that we had no evidence on whether they would work or not, that had a very high chance of having a lot of adverse effects because they were not precise measures dealing with just the virus. They were affecting society, economy, health at large. And at the same time, we had very limited information about what was exactly the enemy we were dealing with, how lethal it was, what was the infection fatality rate, how widely it could spread, whether there was some plateau or threshold of immunity that we might expect to see, who were exactly the people who were at high risk, how steep was the gradient of risk across different people, across different settings, what exactly we had to protect primarily in terms of focusing our attention. Was everyone equally at risk? Was every setting around the world, every location, every job, every institution, every facility at the same risk, or where there were some that were at much higher risk? So we were making decisions without knowing much about any of these aspects, and that made me very nervous. Of course, if you do not know much about these dimensions, but you include within your possibilities one scenario where this would be a virus that will kill the equivalent of influenza in 1918, 50 million people, and in 1918 it was 28-year-old people on average age, then you need to do everything. You just need to shut down everything until you figure out whether you're indeed dealing with this or not. So the draconian measures were clearly indicated when we didn't know exactly what we were dealing with, and we had that huge uncertainty. But at the same time, we had to move very fast to collect information on all of these fronts, or as many as we could, in a reliable fashion, to try to adapt our response to make it more appropriate, more precise, more focused, save more lives, at the end of the day.
Mm-hmm. Well, there was information from China, of course, because they had a quite large, relatively large problem in Wuhan that should have at least, for example, given an indication about the age distribution. Um, is it so that from the very beginning, let's say in the United States and Europe, was there an adequate mobilization in the research community to actually get reliable data, or was there, for some reason, not enough work done?
I think that we saw tremendous mobilization. We saw tens of thousands of scientists trying to work on this problem. And I think that this is really a sign that the scientific community is responsive to major challenges. At the same time, the vast majority of work that was being done probably was less data focused and data oriented and more focused on theory, speculation, and modeling. We saw a lot of modeling studies. In the first few months, probably the large majority of studies were modeling on very thin data or even no data at all, making very strong assumptions or making extrapolations based on the early data that we had seen from China, which with some retrospective view of what has happened are not necessarily representative of what happened to the vast majority of locations around the world. So I think that it's very inappropriate to blame people for doing the wrong thing, because if you have a new virus and you have limited information, it's very likely that you will be wrong in whatever you do, and gradually, iteratively, you will get it right. But I think that we were facing a situation where there was a debate of whether the problem was so acute and so serious that we should not even collect data. And this is where I felt very uneasy, that we just shut down everything and that will do the trick, because people suppose that this is what did the trick in China, which I can challenge quite a bit on whether that was the reason that eventually in Wuhan we saw some control of the epidemic. I think that there were very different approaches. We see now, and this is something that I said from very early on, that countries and locations that did very aggressive testing very early on, like Singapore and Taiwan, South Korea, Iceland, they did extremely well, because they managed to get the epidemic very early on and not let the epidemic wave rise and spread very widely, and then it's a much easier job to deal with it. But then in other locations, I think that this recipe didn't happen, or it didn't work. Some locations probably it was even more difficult to work if you had seeding of the virus in many, many places and in many ways, and it would be very difficult to track all of them. So we had a mixture of success stories and failure stories and in-between stories, but the common denominator was that places that base their decision on data, on testing, for example, and those that managed to protect people who needed to be protected, they did much better.
Mm-hmm. Well, I know this.
Jonathan, can I just jump in there for a moment, because it mentioned the situation in China. One of the things that, I mean, we're in Hong Kong here, of course, and that was next door, right? Not exactly, but sort of close to next door. And while we watched how Wuhan was, basically shut down, and the entire province was shut down, the actual spread in China was very limited, very slow. It didn't really affect either Beijing or Shanghai in any massive manner. It certainly did not in the initial wave make its way into Hong Kong virtually at all. I mean, we had a few cases, but it was negligible until just a month ago or 2 months ago. We only had 4 deaths in the city of Hong Kong of 7.5 million people. So what this raises the question is, how do we account for this astonishing variance. Say in Western Europe, you look at Germany compared to the UK. You had a factor of what, 5x or so of deaths in the UK compared to Germany. What makes the difference here? What, in retrospect, what would you look at?
I think it's multiple factors, and it's very difficult to be 100% sure because we have never randomized countries to different strategies, and I'm not saying that this would be easy to do. Each country and each location had its own features in terms of connectivity with the rest of the world, especially with centers of the pandemic. You know, locations in countries that closed their borders to Wuhan early on, they got very little or no people coming with the virus. Locations that managed to apply social distancing, regardless of whether that was because of measures that were applied by the government or because people were sensitized and convinced that there was something going on and they had to do something, also did very well. Locations that did more testing, early on especially. I think that once the situation is out of control, testing has less ability to contain the epidemic compared to the very early phase. But those that did very early testing aggressively, I think they did very well. Age structure is also a great consideration. Many of the locations that were hard hit, like northern Italy, they have a very elderly population. And it's not just the elderly population itself, it's also the fact that many of these elderly, frail, debilitated individuals were clustered together in nursing homes. We see that in Western Europe and in the US, anywhere between 40 to 80% of all deaths happened in nursing homes, which is really a disaster. In Minnesota, it's even more than 80%. Across the US, it's about 50%. In Belgium, it's about 60%. Northern Italy, these horrible pictures that we saw in Bergamo, there were many nursing homes that were completely decimated with the widespread of the infection in the population and then to the vulnerable people. Nosocomial infection, the ability to avoid or not avoid nosocomial infection did make a difference. Again, if you have the virus spread to the hospitals and infect physicians and staff and personnel, you have lots of vulnerable patients in the hospital environment. If they get infected, they may have very bad prognosis, many of them. And we saw that both in Wuhan early on. Actually, in many of the early series from Wuhan, we already saw that a large proportion, up to 40% or more of the people hospitalized were healthcare workers, physicians and other healthcare workers. In northern Italy, we saw the same thing. We saw massive infection in some locations that were the most badly hit. In the US, we have data now that they show that we had a similar problem. In Spain, we had the same problem. So there were multiple factors. You need to superimpose the mobility of the population, population density, transit systems, like New York has the most popular and widely used transit system in the world. You cannot compare Queens or Bronx in New York with rural Montana. You cannot compare things that are very, very dissimilar. If you take all of these factors into consideration, I think that now we know quite a bit about the different factors that led to that diversity, but we are still learning. We don't know everything.
Mm-hmm. I'm wondering a little bit about exactly this question, because some of the things you have just said should have been relatively clear earlier on. I mean, maybe there was not a whole lot of data, but I recall in Germany, there was very early on, I guess from a study from Oxford, or so there was one model study that had a big effect, that 60% of the population could become infected, and then you would take the 4% infection fatality rate figure or something like that that was coming from China. And it's clear that when governments ask virologists, what's the worst case scenario? Well, that's the sort of thing that they obviously react right away. On the other hand, the real crackdown in Germany came, as I recall, as a result of the pictures of what was going on in Italy. That's the big shock that came along. And that leads me to two questions I wanted to ask. Firstly, just before I forget it, you talk about testing and testing early on. There are quite a few virologists also today who are saying we don't test enough. For example, in Germany, where there's still at the moment a very small number of cases, identified cases, that we should be testing much more. On the other hand, early on, was it not a problem that it was very difficult to test? There was not a great capacity. I suppose you're talking about PCR tests,
Yes.
which are quite expensive and difficult to do. Was that a limiting factor, or was it more a decision-making process?
I think it's both. Of course, a PCR can be set a price at any price you want. You can sell a PCR for $1 million, or you can sell it for $20 if you wish. I think that PCR is a technique that has been out there for many decades. It's very easy to do. And I think that even though I fully agree that there were logistic problems in scaling up the testing machinery, it's not a test that is difficult. And now we see that we can do massive testing. And I think that if the focus had been more sharp, that we need to do more of that, probably more could have been done. Of course, testing is not perfect. You know, testing has false positives and false negatives. Testing can create also a false impression about what the epidemic means, especially if you have a test that doesn't tell you whether someone is contagious or not. It doesn't tell you anything about the severity of the disease that someone will get who just tests positive. But in principle, for a pandemic of that sort, in the early phase, being able to test and to scale up your testing very quickly is something that can make a difference. It is important even later on, but later on the horses are out of the barn. You know, it's very difficult to have a policy of testing and contact tracing if you have 10% of the population being infected. The people who they have been in touch with is almost the entire population. So, you know, contact tracing in that case means that you just need to find everyone and then tell them that they could be potentially infected. It's very, very different compared to if you have an early situation with very few positives, even easier in situations like Hong Kong or Taiwan or Singapore. You have kind of one route of entry, and you know where the enemy is coming from, you know, enemy quote unquote, and how you can contain that enemy virus more effectively.
Having been in Hong Kong initially during the time of SARS in 2003, and then seeing it sort of come back in a nastier fashion, one thing I think that made a difference between, say, what happened here and what happened elsewhere is that people actually knew about it. You know, they were, you know, from the get-go, without having to be told, they were wearing face masks. You know, even now in Hong Kong, when we have, you know, fewer than 10 cases a day that are new, and most of them are easily traceable, you barely see anyone outside in Hong Kong who's not wearing a face mask, let alone inside. So, you know, these, and again, obviously there should be some data collected from the standpoint of future prevention and mitigation, right? On just how effective this kind of thing is. But I actually wanted to ask you a bit more of a controversial question. I mean, how much did the politicizing of this whole situation actually affected either negatively or positively? In other words, when you have a politician who is in a position of authority, essentially saying, well, this ain't so bad, you know, it's just another flu. And you have another politician who says, well, you know, we're studying this closely and this could be quite bad, and here are the things that you need to do. You know, I'm sure that there is quite a difference in this regard, right?
I think that politicizing science is horrible, and politicizing SARS-CoV-2 and COVID-19 was a major disaster. I understand why this happened, because it was a major problem. It had major consequences on the everyday life and death of millions, billions of people. There were major decisions made that affected lives and livelihoods. But I think it was really bad that eventually people started taking sides on scientific questions based on what their ideology and what their party inclinations had been. And I faced that trying to do science in this period, as many other scientists. It's really impossible to try to study a phenomenon and come up with a number, with an estimate of some feature, like the infection fatality rate or the spread of the virus or the risk gradient, and to have to think, what do different parties or different politicians think about these numbers? What side have they taken? If I come up with an estimate, would that be in favor of this politician or the other politician? That's horrible for science, because it creates a lot of tension. It creates a situation where scientists are very reluctant to share their information. I know of many colleagues who are great scientists and are doing great work and could have contributed more, and who just told me that I just don't want to be involved in this situation because people get smeared and people get attacked from political ideology. And if I say that the infection fatality rate is X or Y, I will be smeared by that political party. If I say that it's that number, then I will be smeared by another political party, which clearly does not allow science to do its job. I think that people should try to dissociate science from championship and partisanship of politicians. Science should inform our actions. Science should be free to come up with the best estimates regardless of what politicians think. And if some politicians are more right than others, that's fine. But that should not really be the issue. The issue should be about getting it right as a society and saving lives.
Let me just jump in on this question of that you're raising here, because here in Germany there was also a how should I say, apparently disagreement among virologists and people who are watching that professionally about this specific issue of the infection fatality rate. You probably, maybe it was part of your own meta-study. Here, Professor Streeck from the University of Bonn made a study in the town of Heinsberg, where there was a super spreader event, whatever that exactly means. In any case, it looks like just a single person in a certain situation caused a large number of people to become infected. In any case, Professor Streeck in his study came up with an infection fatality rate in the same ballpark as what you have mentioned in your paper that I have on the seroprevalence data and the other one, which is between 10 and 20 times less than the figures that, at least up until recently, have been the estimates that have been the basis of decision making. So, and Streeck also had a lot of problems. I mean, one could notice the rumblings, and here it was apparently also partly a methodological issue, or not. But you have some comment on that?
Well, I know the Gangel study, and I think that it was done by competent scientists, and it was well done. It was an early effort to try to capture information on an important problem. I know that it came under severe attack, like some of the early studies that I did with colleagues at Stanford and the University of Southern California. And I think that scientific criticism is very important. Constructive criticism is how science makes progress. And personally, when I hear scientists criticizing my work, I feel that they're my benefactors. I feel privileged to see that someone is interested to spend their life, their time the research that I've done and tried to improve it and correct it and make it better. At the same time, there is a boundary where criticism reaches the point of eliminating science, just becoming an angry commentator who wants that result to go away because it doesn't agree with someone's preconceptions. The preconception was that the infection fatality rate must be 20 times bigger, as you say, and look at that result, just eliminate it, destroy it. It doesn't exist. I think that that's not science. This is zealots, this is religion, actually religious war in a sense rather than science. And I think that we all benefit when we manage to improve all the pieces of the scientific studies that are being done and then look at the big picture. I think that gangrel is a very nice point contributing to that bigger picture. I'm sure that other parts in Germany probably had higher infection fatality rates compared to gangrel. Perhaps some had less. Most places in Asia have tremendously lower infection fatality rates compared to gangrel. If you take, for example, the data that we have from Iran, from Japan, from China outside of Wuhan, in terms of seroprevalence, if you take India, the latest seroprevalence studies that have come out, if you take Singapore, I haven't seen seroprevalence data, but I've seen just the number of cases that they have detected. It's about 57,000 documented with PCR, and they have only 27 deaths. Even if they miss nothing, the infection fatality rate in Singapore is less than 0.05. And if they miss half of them, it's like 0.02%. So each setting and each study is giving us a point. And we need multiple such points to be able to understand what is common, what is the average, what is the median, what is the range, where do we do very well, where do we do very poorly, and why do we do well and why do we do poorly in different settings. Then we start gaining scientific insights. If we just fight to eliminate science and to eliminate data that we don't like, that's self-destructive. And I'm afraid that that's what happened in the case of the gangrel study and the attacks that it received.
Mm-hmm. I think if I may just add.
Oh, yeah.
I mean, there is, if we want to get back to the science issue on one question, on the transmission question, which I think is a very, very big question from a practical standpoint. But obviously, and this is in Germany, a very big question, decision makers will ask the question, who are the ones that are going to be responsible when a lot of people die, when there's, a disastrous situation. They're saying, well, my goodness, if it gets out that the fatality rate is so small, people are not going to take it seriously. And if people don't take it seriously, then we're going to get larger or smaller disastrous situations going on. So how do you get a population without telling them? Now, I have the figures from Euromomo, the mortality figures in Europe. And if you just look at them, you see, well, this is in terms of actual deaths in Europe as a whole. Of course, Italy, Spain, UK have contributed mostly. You see that it's worse in terms of full numbers than the big influenza epidemics that we had in 2017, 2018. However, the age, as you pointed out, the age distribution is very different. But what would you say, because that's a hot topic. Is it like influenza? Is it not like influenza? I think decision makers have the idea we have to keep the population scared, or at least find a way so that people take it seriously, because otherwise we're going to have a big problem.
Well, it's a tough issue, but my personal belief is that you should try to convey to people, the whole population, what we know as accurately, as precisely as we know it. I think if you try to exaggerate, or conversely, if you try to underestimate, sooner or later it will backfire. And I think that that's what we're seeing to a large extent right now. Many segments of the population have started seeing that many of the pieces of information that they were given, they were grossly inaccurate. And I'm not saying this to blame anyone. I think that maybe the intentions were the best intentions there could ever be. But some of the pieces of information that were circulated were not consistent with themselves. They were very inaccurate. Some of them sounded very, very scary, and probably the reality was not that bad. People will find out sooner or later, and I think that you would not expect that all people will be just very reasonable and calm and continue life as usual under these circumstances, especially when the measures that have been taken have been draconian and they have devastated many of these people. I think that we need to be very careful to convey information as accurately as possible, to convey uncertainty about information. We have to say we just don't know. I think if we try to pose as scientists who know everything about a disease that we had no clue about a few months ago, that we didn't even know that the virus existed before December, how can we make that claim? It's impossible. There's a lot that we do not know, and a lot that hopefully we will find out that will be very useful to deal with this dreadful pandemic. But just trying to scare people, that's not a solution. You know, people who get scared, they will be scared for a day, for a week, for a couple of months. Then they will just become angry, very angry. And this is what I wrote back in my early papers, that, you know, we could get civil strife, we could get wars, we could get rioting, we could get people just acting crazy under the circumstances.
I think you, of course, one has to add in the case of Germany that there are a lot of people stirring around the muddy waters and putting things in which really have nothing to do with the virus. But I wanted to just, again, before I forget, to get to question of real knowledge, and that is, practically speaking, what do we know about transmission? Because people are being said you have to wear masks all the time, but it's not clear how effective the masks are. So you have people that are wearing masks, and then they go to a family party but usually without masks. Then you get real large spread. Older people die. So what actually do we know with reasonable probability about what the really big danger areas are, where the probability is very significant, and what are measures which are probably have marginal effectiveness?
Yeah, let me ask just a quick follow-up that goes with that. I had a question here from the audience. I mean, we still have, this is a very practical question, what to do. In the United States, we still have, 40 to nearly 50,000 new cases per day, and 800 between 1,000 deaths per day. Now, this is, 6 months into the pandemic. Have we not learned anything at all to really deal with this thing at this point? I mean, I think after 6 months of seeing this pandemic rage, what have we learned? And you know, getting back to Jonathan's point, how do we get the point across? How do we disseminate that in the, you know, the educational component of that? What needs to be done?
So that's a question that probably can take 10 hours to,
yes.
to answer with just the preliminary introduction. But basically, we can think of the pandemic, if you separate it into two big buckets. One is epidemic waves that we have contained or we can contain. And these are the success stories that we have discussed just a few minutes ago, where we acted very early and things did go very well. Now, this doesn't mean that the epidemic cannot hit these places again in the next few months. And maybe, you know, if we're not vigilant enough, they can also get out of hand. Then you have the other bucket where the virus has spread very widely. And the US is one such situation where the virus has spread very widely. I mean, you mentioned 40,000 new cases per day. I would argue that, in fact, you have to multiply that probably by about 10. So, you know, it's probably close to 500,000 every day, which is a huge number. And where you probably need to have a different strategy about what you're aiming to do at this point and how you're trying to save lives. Then you focus, I believe, on what we have learned on what are your priorities to protect. Mm-hmm. Number one priority, nursing homes, because 50% of deaths more or less happen there. It could be 60%, could be more. What does this mean? It means that you test personnel routinely, you test residents routinely, you have draconian hygiene measures, you have draconian infection control. Number two location, hospitals, nosocomial infection, same thing. You need to test personnel, you need to test and make sure that you don't get the virus to invade hospital environments and start killing people within the hospital environment. Number three, a number of locations where you get super spreader events. We have now experienced from hundreds of super spreader events, and we know that there are some locations that are clearly off the charts in terms of risk, like, you know, meat processing plants. We've seen that again and again and again. You need to protect these locations with very different measures. Number four, look at the population. Who is at risk? We are lucky in a way that COVID-19 is a virus that has tremendously steep risk gradients. In epidemiology, we're very happy when we find a risk factor that doubles the risk of getting a disease or a bad outcome, or makes it 50% if you have it versus not having it. In the case of COVID-19, we have risk factors that increase the risk 100-fold or 1,000-fold. If you compare an 85-year-old versus a child, there's difference in risk, especially if that 85-year-old has substantial disease. It could be more than 1,000-fold. So you can focus on like 10% of the population that really needs very draconian protection, as opposed to the large majority of the population that probably does not necessarily need that in terms of the level of protection, and probably they can still do their usual life, live their usual life with some measures that would be efficient, but not as draconian and as restrictive as a total lockdown. And then you have evidence about individual protective measures that work. We know even with randomized trials that washing your hands does decrease the risk substantially. We know that masks, when worn in proper situations and in a proper way, they can also make a marked improvement. You know, for example, we have evidence even from randomized trials from the time of influenza that infected people need to wear masks. That's very helpful. That people who deal with infected people also need to wear masks. COVID-19 has many people who are asymptomatic. So if you're in a situation that you have a high risk of exposure, wearing masks does make sense. At the same time, we need to make sure that they're worn in a way that they do work, because it's very different when we're talking about efficiency of a measure under ideal circumstances and effectiveness of a measure when people just try to do it, but they fail to implement it in the way that it should be implemented. I mean, if you wear a mask, but you don't wear it properly, if you just put your hands in your mouth and your nose while wearing the mask, or even more because you're wearing the mask, if you wear the mask to go out to mass gatherings with thousands of people around you, 70% of whom do not wear a mask or wear a mask in a way that doesn't work, you know, again, you're even getting false reassurance that, oh, I am protected or I am protecting others, but actually that's not the case. Big events with thousands of people attending, they don't make sense if you have a situation where you have a brewing epidemic. And especially for people who are at high risk, they make absolutely no sense for them to be there. So lots of these targeted measures make sense, even common sense, I would say. We do have science to use them, but all of them do not require shutting down society, do not require shutting down the world, which is what we did early on, which retrospectively seems to be a huge mistake. Again, not blaming anyone because we didn't know, but based on what we know now, it just seems like a horrible course of action. And I hope that we avoided by using more precise, more targeted measures that hopefully can still save lives.
I have a question here from just on this issue of masks. I don't know if you specialized enough to know the answer, but someone in the audience has, can children wear face masks securely and safely?
I want to be honest. We don't really know that. I think that there's a high chance that I used the term efficiency and effectiveness before. And I think that this is a situation where the difference between efficiency, which is the ideal theoretical protection, versus effectiveness is quite large. And I think that we need to be honest about this, about our ability to use masks to contain spread within a population of little children. I think that I don't want to enter a fight with colleagues who feel very strongly about this, but I do have some concerns about that divide between efficiency and effectiveness in these circumstances.
Yeah, thank you. We're now at a point in our discussion, I think, where we could invite some audience questions. We have a number of them that I'll look at in a moment. But just prior to that, what are we going to do to make sure going ahead that we don't run into this kind of a situation again, where for a long time we don't know what to do, and then we try out everything and we still don't know. That should be avoidable, right? You have used artificial intelligence methods, other methodologies, big data methods. What's the way of the future here, other than vaccines? I mean, that we all hope for, but what else can we do to deal with this situation?
I think that each virus is a new virus. When we discover a new virus that is a potential human threat, we start from scratch. We cannot generalize from previous knowledge. I think that in the case of SARS-CoV-2, we probably overestimated its capacity to kill and create a disaster. It is a lethal virus. I'm not going to deny that. I never denied that from the very beginning. But it clearly has nothing to do with the footprint of 1918 influenza, where we're talking about 50 million people dying with an average age of 28. In terms of impact, it seems very close to bad years of influenza, bad seasonal years, probably less than the worst 1957 and 1968 that had 1 to 4 million deaths and had also lots of young people dying in some of these occasions. For a new virus, we just need to act swiftly to get data. And I think data science is mature enough to be able to collect that information in real time. I think some of the pivotal studies that were done was, for example, one published in Nature by the Open Safely group in the UK, Ben Goldacre is the senior author, where they very quickly matched information on deaths from COVID-19 against huge databases that existed for the UK population. And they could get some very nice information on mapping the risk of different people. How much would risk increase if you had diabetes, if you had obesity, if you were poor, if you had asthma, if you had immunosuppression, if you had cancer. This is tremendously important information. I think that when a new virus hits, which I hope it doesn't, but unfortunately it will at some point, sooner or later, we need to act very swiftly to collect data and massively analyze data. Not try to eliminate data, not try to fit things to our theories or our beliefs or our expectations or our ideology. Be open-minded, collect data, clean these data as carefully as possible. Don't trust single studies, trust multiple studies. Try to trust the totality of the evidence from multiple studies, from multiple ways of addressing a given scientific problem. Did we do that with COVID-19? We did it to some extent, but I think that there was also so much tension and so much ideology and so much noise and so much people being upset or having other priorities in some cases, that we had a rough time to eventually converge in getting some knowledge. And I'm not sure that we have even fully converged yet.
Yeah. There's an interesting question that, I had in my own mind. This comes from some participant in California, asking, is there a genetic difference in the makeup of the human being that may a certain virus, be more lethal or more infectious or what have you to certain types of people than to others? I mean, it's a striking fact that the lethality rate, the infectiosity, and all the rest of it in Asia seems to be just an order of magnitude less than in Europe. Now, this is a tricky business, right? Because then you get involved in racial differentiation and other kind of situation, and many people don't want to touch that with a 5-foot pole. But is there actually some evidence that genetics may play a role in this?
There is a line of research that is looking in this direction. We have some preliminary data that I think hopefully we'll have more in the near future. For most viruses, it's very likely that there is a genetic component in terms of the host genetics, in terms of how we handle the virus, how easily the virus can be transmitted, and perhaps also how severe the outcome would be. In many cases, many of these genetic determinants are in the HLA, the MHC system, which is a set of genes that control the immune response for a general audience. That's an oversimplification, but I think that it's fair to say. And there's many other genes that have come up as potential regulators of the immune response and eventually also the clinical chance of getting infected or getting severe disease for viruses like HIV, for AIDS, or other pathogens. So I think it's possible that we may be dealing with some genetic architecture in the host that may be different in different populations. There's many other components that might explain the differences across different countries, though. There could be differences in the background immunity of the population, and currently we know that there is existing cellular immunity probably to other coronaviruses that gives cross protection to the new coronavirus. And I think it's very likely that different populations have been exposed to different extent and have developed different levels of that cross immunity based on their past exposure experience before the advent of SARS-CoV-2. So it could be both the host and the virus and other viruses, and also the architecture of the immune system that might be responsible for some of the differences that we see beyond the classic epidemiology, like age structure. You expect to see a lower infection fatality rate in India and Pakistan compared to Italy because you have 10 times fewer elderly people, just to start with.
Could I just jump in with, sorry to interrupt, but since this is such a hot issue and I notice these questions coming, we'll get very quickly to the vaccine thing. I mean, I personally think getting better treatments is, I mean, they don't exclude each other, but it would be very good if we had better treatments for influenza and other diseases which have a somewhat similar viral influenza, viral pneumonia as a general medical problem. It would be great if we found, if we could make a real breakthrough, because a lot of people die of influenza also. But how do you see this vaccine issue? Are you optimistic? How much would you say better treatments or vaccine, do you see that? How do you see that trade-off, let's say?
I'm a big believer that vaccines are a tremendous achievement of humankind. And I think that some vaccines have really made a difference in saving millions of lives. In the case of coronavirus, I'm cautious. I just want to see the data. I think I would be a fool to tell you that, oh yes, we will have a very effective vaccine, or to just tell you that we will not have a vaccine. I think that without seeing the data from phase 3 trials, anything would be entirely speculated. I'm a little bit on the pessimistic side because we have not really done well for developing coronavirus vaccines for humans even though we've known coronaviruses for many decades now. And one might say that this is an issue of commitment, that we never really committed to do this. Well, now there's clearly tremendous commitment to come up with a vaccine, and everybody's expecting it. But I'm not sure that this is just as simple as that. If you think about the architecture of the disease, those who we need to protect are people who are likely to have the least capable immune systems. That 50 to 60% of deaths that happen in nursing homes, these debilitated patients unfortunately have very little room for immune response. And I'm not sure that this will be a population that will be easy to protect. The same applies to people who have multiple other severe risk factors like immunodeficiency or active malignancy. Again, they may be people who are not the best to develop the proper immune response. I have no clue about what the duration of immunity would be. We know very little about what are the best components of immunity that we need to aim for. I started working on measuring antibodies, but very quickly we realized that this is just a surrogate of the immune response. And actually, apparently antibodies go away very quickly in many patients, or many patients do not even develop antibodies at all, but they can still handle the virus. So there's a lot that we don't know about how a vaccine would work, whether it would work where it is supposed to be effective, and we want it to be effective. And therefore, I want to see the data. I'm glad that we have large phase 3 trials. There's at least 7 or 8 of them that hopefully we will have some data soon, and we'll need to scrutinize them very, very carefully.
I have a question here from some viewer who wants to know, what do you consider the most reliable source of information on this whole situation, whether it's vaccine or anything else? Is it the CDC? Is it the WHO? Is it, I don't know, the people at Johns Hopkins University who have given us all the numbers on all of this? Where would you look? I mean, if you are trying to figure out, hey, what should I do? Should I wear a mask or not? Should I, I don't think anybody disagrees about washing hands. I think that is sort of rather normal issue of hygiene. But where do you go when you want to know what's real and what's just some wild rumor?
For the average reader, for the average citizen, this is a nightmare. And even for specialized scientists, it is extremely difficult to navigate the waters, because there's just tons of information. There's even more misinformation than information. For someone who's not a specialist, being able to differentiate between what is valid science and what is just fake news or something that has no value at all is very, very difficult. Actually, we have evidence, even from the pre-COVID era, that fake news travel faster than real news. And science really is at a disadvantage against many of the sources of fake news. Even within the scientific literature, much of the scientific literature is very unreliable. And in COVID-19, just because we tried to move very fast, we had to cut corners in many cases. And this means that it's even less reliable on average compared to what you would see under regular, let's say, normal, calm circumstances. This doesn't mean that science is bad or that we should not trust it. Science is the best thing that has happened to humans. I cannot say that enough times. But even science has a cycle of maturity. It takes time to mature. It takes time to be self-scrutinized by scientists, by peers, by colleagues, by additional data, by contrarian research that might destroy some of our early beliefs. So it's not easy. I think that for the average person trying to consume information, it's a very, very difficult time. And I think that this is why we see so many people being upset, so many people really coming up with very weird ideas, conspiracy theories, just complete havoc sometimes. Yeah. My only suggestion is, just try to be calm. The vast majority of people are not going to die from coronavirus, but it is a serious threat. There is some science out there there are some sources, as the ones that you mentioned, CDC, WHO, they're trying to do their best. Even what they have is not perfect. It's not bulletproof all the time. Keep some caution. Don't be angry about it if things are proven to be wrong. Just try to do your best and try to live through that and not panic and not get depressed.
There is a question from a viewer in China, and it's a politically, I think, very obvious kind of question that could also be asked in many other parts of the world. But of course, it's very acute, maybe, with the situation in China. If we collect all these data, we collect all the genetic information, both on individuals and in other kind of contexts, what does that do to personal freedom? What does that do to, my own privacy? How is this going to be used? How do we deal with this?
About this. I'm really, really concerned about this because some of the measures that were taken early on really invaded personal freedom and privacy, and they challenged some of the fundamental democratic dimensions of our lives. Now there's a trade-off. There's risks and benefits in everything that we do. So if coronavirus were to kill 50 million people of average age of 28, I would say, shut down everything and forget about privacy for a few weeks. If it's an issue of a few weeks, we'll deal with that. And then we will be very happy and we will all celebrate and we'll just burn these 3 weeks of our lives as being completely miserable. But that's not the case. Coronavirus is probably here to stay. I don't know about the next waves, how big they might be, whether this virus will get established in the community and maybe coming back with some modest or more than modest waves in the future. That's very hard to say at the moment. We cannot really destroy our lives. We cannot destroy democracy. We cannot destroy privacy. We cannot destroy our world for something like that. We need to deal with it precisely with as accurate tools as we have, but not destroy our world. Because our world is 7.7 billion people, and it's also all the people who will live after us. And we cannot kill all these lives just to contain a virus, which is lethal, but is not the end of the world.
There's a question from a viewer not identified the country, but we asked about Sweden. There's been a lot of talk about Sweden. The Swedish exceptionalism here. What is your opinion on that? Was that sort of worth a try, if you will? I mean, let's suppose for a moment even that they really messed up when it came to protection, of the people, the older people most at risk. But other than that, would that have been, well, you can do it in Sweden, but could you have done that in the US? Could you have done that in China? I don't know. What's your view of that?
So I have great respect and even admiration for the Swedish team. They did something that was against the odds and against probably the majority of voices screaming to them that they were just doing something horrible. And I think that you can interpret the results in different ways, but the way that I read the results that they got is that their decision to keep their society pretty open, but at the same time, really communicate to the population that there was a problem and they need to take these precise measures. They need to avoid mass gatherings. They need to use some social distancing. They had to use hygiene. And eventually the population was convinced, and they did use that without necessarily shutting down the entire society, the entire economy, their entire country. I think that was a very big benefit. At the same time, as you mentioned, unfortunately, they missed the opportunity to protect some extremely vulnerable populations. And in fact, some of the regulations regarding personnel at nursing homes were devastating because people who were infected really did not take time off and were not tested, or both. And then they had massive deaths in nursing homes of vulnerable elderly individuals. But we should not confuse these two components. One is the social intervention, the country level intervention, the political, let's say, intervention. And the other is the handling of a specific setting or specific environments. So I think they did very well on part one. They did pretty poorly on part B. I think in the future, more countries should try to consider the Swedish model, especially in situations where you cannot eradicate the epidemic wave before it starts. You know, that would be the ideal. And I mentioned the success stories that we had with that paradigm. But if you miss the boat for that first opportunity, then I think for something that is a long-term problem, and it's not just a couple of weeks, it's probably several years, a situation where you take the right precise measures and you still keep your society open probably is the best.
There's a question actually from Sweden, which the question is, we are, at least up in Sweden, coming up against winter. Does, in your view, temperature and temperature zones, do they have anything to do with, do we have to worry that the winter now brings a second large wave before we really get to any vaccination?
So there's a lot of literature about temperature and humidity dependence of coronavirus with some mixed results, but let's say that the consensus is that there is an effect of temperature and of humidity. It's not definitive, so if it were definitive, then probably in many countries we would not be seeing a surge in the summer months, but there is clearly some potential for seasonality. Would there be a second wave in Sweden in winter, or let's say later on in winter to spring? Nobody knows that. But to be honest, we don't even know every year how big the influenza wave is going to be. We just try to grapple with some information initially from the Southern Hemisphere and then try to make some predictions for the Northern Hemisphere. But every week and every month is a new week and a new month. And we have lived all these decades and centuries with that uncertainty without really destroying our lives. I cannot tell you whether in 2024, influenza is going to kill 350,000 people around the world or 800,000 people around the world, or whether it's going to be a really bad year like 1957, it's going to be 1 to 4 million people dying. We don't know that. We would not know that even 2 months before that year starts. At least based on our current knowledge. So do I commit suicide because of that? Of course not. You know, there's so many uncertainties in life. This is just one out of a million uncertainties surrounding us, but we still live our lives. So we need to be vigilant. We need to be prepared. We need to have our hospitals in battle station, let's say, that they need to be prepared for influenza, for coronavirus, potentially for a new virus. We need to have public health. And many countries, unfortunately, they have not paid enough attention to public health, and they just scramble at the last moment to try to set up facilities for public health functions. That's not easy to do overnight. But other than that, I think that we should just be calm and see what happens. Most likely, I think Sweden will not have another devastating wave, but I cannot promise you that. I don't think that anyone knows that, to be honest.
Yeah. Jonathan, you have any follow-up there?
Well, I think that's a very, very important point. And again, I'm thinking about, of course, the situation here in Berlin where we had this huge demonstration and people very shocked in different ways by this, because it showed a kind of split, let's say a split consciousness in the population about the reality of what's going on. People are afraid, and I can sort of, in a certain way, kind of feel both of these worlds, not the wild conspiracy theory world, which is really crazy, but it's existing in a certain environment where people are afraid but also feel they're not being given the full story. And I think it's very important what you're saying. The full story is not there, partly. So people have to put up with this. But again, maybe to get back to something that Uwe was mentioning, when you talk about, some people have been warning that with the increase in mobility of the world population, which is in a certain sense unprecedented. I mean, it is unprecedented. Somebody can get on a plane from China to go, we saw that actually happening. But within a very short period of time, hours, you can have a epidemic spread. So secondly, people have been warning with some plausibility, it seems to me, that we're also going to have an acceleration of new viruses that can spread into the human population. For example, from animal reservoirs. And this discussion about, well, did the virus emerge in this market in China or from somewhere else? But it raises the issue of, you said people, do we need or should we build up a kind of infrastructure and strategy which is ready, like when the fire alarm goes off? You're ready, you have certain kind of methodology, and you're not improvising from one virus to the next one, even though they're very different. You have recommendations. Since, as you say, this is not the last time we're going to be faced with this, also maybe we can do better with influenza.
Absolutely. You're right that there's a lot of unpredictability about other viruses really emerging, and we have a world that is highly connected and highly mobile, which means that new pandemics can spread very quickly. I think that the answer should not be that we shut down our world preemptively, because then we just destroy ourselves waiting for the new virus that never comes. At the same time, there's lots of things that we could do. I think that we could prepare our public health systems. We can prepare our hospitals. You see some of the locations that were hardly hit, like northern Italy. Italy, unfortunately, had slashed the number of beds and ICU beds that they had. And they came up with a crisis that they just didn't have the facilities and the number of beds and resources to deal with. So it's very difficult to build resources just within a few days. It's something that you have to have some advanced thinking and advanced planning and be prepared for something that might hit. At the same time, I believe that we should not convey to the population a sense of perpetual threat. There are threats, and a new viral pandemic is one such, but I think that it would be a mistake to try to keep everyone on alert that, next week, next day, next hour, there's going to be that new virus from China or from some place that nobody knows in some secret market, or even worse, some conspirators are building it right now in the lab. I think we should try to be calm. I think that there is a lot that we know and there's a lot that we do not know. We should prepare. We should try to be tolerant of people who have different opinions. I'm not talking about endorsing conspiracy theories, but people who are scared, people who feel that they have not understood why all of this is happening, people who see their lives and their livelihoods devastated. If you call them COVID idiots, that's not going to help. Who is going to be called an idiot and become a good citizen? I don't know of anyone. I think that these people just become more angry, and if at the same time their lives and their livelihoods have been destroyed, calling them idiots on top of this is not going to solve the problem. So we need to explain. We need to gain trust. We need to gain respect. We need to gain over to knowledge and to science as many people as we can, because then we will see some of the fundamental gains that we've had, some of the vaccines that we know that they work, some of the science that we know that works, being questioned. I think that would be horrible. We will see more things being questioned if we try to impose more certainty on what we know and what we should prepare.
Mm-hmm.
Great. Well, thank you very much, Professor Ioannidis. We've kept you for a long time. I've gone through a lot of the questions that were asked by the audience. I couldn't carry them all. There were 39 questions altogether. So we've people from around the world. Somebody is greeting you from Paraguay. Maybe you know somebody there. So in any case, thank you very much, but I think we will conclude this at this point. I think your final words there that you just spoke, are very much apropos. The attitude is that people should adopt to this kind of situation. And once again, thanks for all the people who attended, and of course, to you, Professor Ioannidis, for taking the time to address some very tricky questions. Thank you very much. We're closing. Thank you. Bye-bye.
Bye-bye.